Bismillahirrahmanirrahim. Assalamu alaikum. Today we are discussing sinusitis and rhinosinusitis. Actually, sinusitis and rhinosinusitis are the same terms. But before going to the actual topics, I didn't receive much reply of assignments from your side. So keep in mind that all the assignments which I will give to you online in these online lectures, they must return to me in handwriting, not in a word or in typing, because on the basis of these assignments, we have to mark your attendance and we have to add it to your internal assessment. So I received message from your CR that I can collect. No one is authorized to collect these assignments. You have to send them directly to me and in your handwriting. And those students who didn't send the assignments in their specified time, they will be marked absent and it will add to your internal assessment. So be careful and be conscious and be attentive to all these lectures which are given to you. So today, after this topic, I will give you assignment, and those assignments should reach me in the specified time. And those who didn't send their assignment, previous assignment to me in the specified time, they will be marked absent and will be add again. I will telling you that it will again to your internal assessment. And we are dealing with all the classes, third year, fourth year, and also because you have a modular system and you have to you are entering in the clinical side. So sinusitis, the term sinusitis and rhinosinusitis are the same. Sinusitis is the previous term which were used for the inflammation of the sinus, but now the rhinosinusitis is a new term which is used instead. And the reason is that no any condition in which only the nose or sinuses are involved isolatedly. So therefore the term rhinosinusitis is there. Next, as I have told you, the nose is rarely affected in the isolation. So the adjacent paranasal sinuses, either to a greater or lesser extent, are involved. That's why the term is changed. It is an inflammation, either it is an inflammation or infectious condition of one or more of the paranasal sinus. And for this, you must know the anatomy of the sinuses, groups of sinuses, pair or grouping. That is maxillary sinus, frontal sinus, ethmoid sinuses cells, and sphenoid sinuses. So you must know the anatomy of the sinuses. That is your job. Then you will be clearly understand what I am delivering the lecture. Acute rhinosinusitis, that is ARS, it is abbreviation, and it is implies to the duration of condition which is less than 1 month or 4 weeks. Whenever the term acute comes, it is usually less than 4 weeks. And the chronic, we usually used above 12 weeks. So most cases of ARS are commonly either a community acquired or associated with some upper respiratory tract infection. From a community acquired infection means that a person is getting infection from community, in a community hospital or social community or somewhere else. And the other are those infections which are in a continuation of upper respiratory tract infection. So there are mainly two etiological conditions in which ARS can be contracted. And the upper respiratory tract infections are exclusively, commonly they are viral. Bacterial comes on the second turn. As it is written that up to 1 in 20 upper respiratory tract infection lead to bacterial rhinosinusitis. It means that viral infection is more common. If we collect a sample, or we can get in a survey of people having upper respiratory tract infection. So out of 100, we will get only 4 or 3 patients that will be having a bacterial rhinosinusitis. Otherwise, 21 out of 20, or the percentage is of viral infection is more common, because initially any flu, common cold, it is viral, then it transforms to a bacterial infection with time. That we'll discuss later on. So how will we divide it? On the basis of location, or immune status, or microorganism. So location that comes into the acquired, that community acquired or hospital acquired, that I have discussed earlier. So patient can get infected, that health workers get infected from the hospital, in hospital from the patients, and community 1% get infected from the other. That we commonly see one of the family member get infected, having a viral flu, and it transmitted to all of the family members in a house or in a joint family living. So immune status, a patient diabetic or immunocompromised due to some other reason, have the much more chances to get infected. And the next is the microorganism. So among the microorganism, viral infection is on the top of the list. Bacterial and fungal come next. The diagnosis of this ABRS means that acute bacterial rhinosinusitis. This is abbreviation. The signs symptoms, and this is for the bacterial. Mucosal thickness and fluid is frequently associated with common cold, acute rhinosinusitis. Actually, the paranasal sinus having a thick mucosa, or a fluid, you can say that the mucosal lining is thickened and fluid is much more. So in viral infections, that is, we commonly call it as a common cold, the mucosal thickness and the fluid is frequently associated. So if we get proper confirmation among the bacterial and the viral, if there is some confusion, so differentiation can be made on the basis of culture, that is culture sensitivity. That you take a culture or nasal swab or throat swab from the patient and send it to culture, and for culture sensitivity, and there it will get that whether it is a bacterial or viral. If it is bacterial, then the pathogen will be isolated. So for proper differentiation, if there is some confusion, then bacterial, this culture sensitivity or culture confirmation is one of the diagnostic process. For the most of the time we get infected, we get resistance for the sinusitis. We get resistance. How we get resistance? If a patient, I have told you that for the most of the time it is viral. So if a patient is having a viral infection and he is boosting upon antibacterial antibiotics means antibacterial drugs, so their resistance will develop against some antibiotics, because it was not required, it was inappropriate, it was not needed. But instead, in the viral infection, the antibacterial or these antibiotics are given to the patient, which is of no use. So for viral infection, there is no as such treatment as antibacterial or antibiotics, either antiviral drugs or nothing, no antibacterial drugs. So antibacterial drugs have no role in the viral infection. So that's why we get resistance against such antibiotics. 50% of common colds are caused by human rhinovirus. Rhinovirus have different types, almost 100 types. So there are different pathogenicity, different pathogens. That is, rhinovirus is the most common one, but it has different strains, about 100 or more. Other viral include influenza A, B virus, parainfluenza, respiratory syncytial, adeno, and entero. All these are involved, but most common one is the rhinovirus. The process of pathogenicity, influenza and adenovirus usually injure the nasal epithelium, and rhinovirus and coronavirus, this is a virus, yes, it can induce minimal damage as compared to the influenza and adenovirus. One other cause, that forcefully blowing of the nose, it is also one of the causative process in which the secretions get propel or get into the paranasal sinuses. So what happens when these sinuses are filled up with these mucous secretions and the intranasal pressure increases, the exudate get viscous, and then it is harder to clear. So increased viscosity and the mucociliary function, mucociliary dysfunctions. Mucocilia, you know that there are mucociliary hair cells in the nasal cavity, in the sinuses, which are repeatedly and in a proper way, they clear the sinuses and the nasal cavity from the secretions. That a mucous blanket is propelled back into the nasopharynx. That function is get affected, and so these exudate get viscous, harder, and it is difficult to clear. So forceful blowing is one of the etiological factor. Among the bacterial pathogen, streptococcus pneumonia, H. influenza, Varicella catarrhalis, these are common, but Varicella catarrhalis are more common in children, that is in pediatric population. Diagnosis: viral upper respiratory tract infections. They have typically symptoms like rhinorrhea. Rhinorrhea means discharging anterior nasal discharge, that is a nasal discharge or watery or secretions that comes out from anteriorly from the nose. One is anterior nasal discharge, that is a posterior nasal discharge. So rhinorrhea here, we mean that anterior nasal discharge. Sneezing, nasal obstruction. Definitely if the patient is having secretions in the nose, nasal obstruction will be there. Facial congestion. Why facial congestion? Because sinuses are filled with fluid. So facial congestion or facial pain is one of the symptoms of the sinusitis. If maxillary sinuses are filled with secretions, so definitely there will be a facial congestion. Hyposmia. Hyposmia means low sensation of decreased sensation of smell. Sore throat, cough. Sore throat, yes, if there is posterior nasal discharge, fluid is going back into throat, there will be sore throat. Cough, if these secretions get access to the larynx, so vocal cords wouldn't allow the entry of these secretion, and a cough occurs, or sometimes due to the laryngitis. Eustachian tube dysfunction, ET dysfunction, means from the nasopharynx, there a way through the eustachian tube into the medullary cavity. So if eustachian tubes are blocked, there are again two reasons. As I have told you that there are some conditions in which the mucociliary function is affected. In the eustachian tube, there are mucociliary functions, mucocilia. So if they are a dysfunction, so eustachian tube will be blocked. Myalgia, fever, these are the common symptoms in the viral. Acute bacterial rhinosinusitis can be considered when we will consider that it is bacterial. The viral infection, if it doesn't resolve within 10 days, or if it is worsening after 5 days, then we can say that there is some bacterial infection is supervening. So up to 5 days, we have to wait whether the upper respiratory tract infection is resolving or not. And if after 10 days it doesn't resolve, or if it gets worse after 5 days, between 5 to 10 days, then it is bacterial infection is there. Some or all of the following signs and symptoms may be present. Yes, nasal drainage, facial pain, decreased olfaction, fever. Symptoms are usually sometimes similar. Then comes towards the X-ray, a plain X-ray or X-ray PNS or paranasal sinus. These are usually we do for the maxillary sinusitis, because on plain X-ray we can see the maxillary sinus and frontal sinus, but ethmoids and sphenoid sinus are not visible or can be observed on the basis of plain paranasal sinus X-ray. In these, we can see air fluid level or mucosal thickness. If there is sinusitis and we do a plain X-ray, PNS, so there we can see air fluid level, because sinuses are filled with air. And if there is a fluid, then it will be air fluid level, or we can see a mucosal thickness or around in the sinus. The recommended treatment for bacterial sinusitis or bacterial sinusitis, these are, in a mild disease, there are two criteria: whether the patient have got any antibiotics in the previous week, or he or she didn't. If the disease is mild and the patient hadn't taken any antibiotics in the prior 6 weeks, then amoxicillin, clomivate, amoxicillin, cefotaxime, trimethoprim, sulfamethoxazole, these are the drugs of choice. And if the patient have received antimicrobial or antibiotics in the prior 6 weeks and still the condition is not getting better, then fluoroquinolones, these are quinolones, actually, group of quinolones. These are given. Second, if there is failure to respond to the treatment within 72 hours, you are giving the treatment and the patient is getting no response within 72 hours, then we have to change our criteria. If for further management options, these are to do a CT scan, nasal endoscopy, culture sensitivity, or sinus aspiration. CT scan, this is computerized tomography we do for the paranasal sinuses. In it, by the means of the way, or we can see a proper visualization of all the paranasal sinuses, ethmoids, maxillary, sphenoid, frontal, or because we get a proper cuts of 2 millimeter, 1 millimeter, whatever we want from the radiological department. Nasal endoscopy, this is examination and diagnostic both. Flexible or rigid we do, and sometimes we do it for taking a swab. Culture sensitivity, I have told you, this is one of the diagnostic. If we get some resistance or the patient is not getting improvement with medicine, then we do culture sensitivity. But for culture sensitivity, it is mandatory to stop the antibiotic for at least 48 hours, 48 or more, so that the result may be a proper, and we get a proper sensitive result from about the antibiotics. Then sinus aspiration, that we aspirate the secretions or the fluid from the sinus, and either for a diagnostic purpose or for the therapeutic. Diagnostic purpose, that we can do culture from that, or therapeutic, that we can clear the sinus. And it can be done by anterior nasal enterostomy or a proof puncture. It was a procedure previously, in previous years it was done to with a needle and cannula. It's a proper needle and cannula, trocar cannula. It was called trocar cannula, and it was entered below the inferior meatus, and then puncture was done, or the bone, through the bone into the maxillary sinus, and the secretions were taken out. There are some complications of the sinusitis, and these are divided into 5 groups: preseptal cellulitis, orbital cellulitis, subperiosteal abscess, orbital abscess, and cavernous sinus thrombosis. But the last two, orbital abscess and cavernous sinus thrombosis, are the worst condition and worst complication of the sinusitis, which have very poor prognosis. So these are the complications of the sinusitis. Then come to the chronic sinusitis. You are discussing all the, actually, you must be clear about this, that these are the complications of acute rhinosinusitis or acute sinusitis, these orbital complications. Chronic sinusitis is actually very much concerned with the inflammation of the nasal paranasal sinuses. And I have told the term is now changed, but the inflammation of the paranasal sinuses. Acute sinusitis, we have studied that it is usually infectious in nature, but the chronic sinusitis, there is an inflammatory process also. It results from inflammatory processes. Infectious processes are a bit lesser in we can say in frequency as compared to the acute. So chronic rhinosinusitis CRS is less frequently bacterial in causation and mostly subdivided into patients with hyperplastic mucosal changes. Which mucosa? Nasal mucosa and sinus mucosa. So hyperplastic mucosal changes are there in the chronic sinusitis with polyps or without polyps. These are two conditions. Means mucosal changes, hyperplastic mucosal changes are there in all the chronic sinusitis, but some patient will present with polyps and another without polyps, nasal polyps. So clinically diagnosis of CRS is the sign and symptoms are divided again into major and minor factors. There are some major factors and minor factors. Among the major factors are facial pain, facial congestion, nasal obstruction, nasal discharge. They may be purulent or discolored, that is, or maybe a post-nasal discharge. And fever, hyposmia, yes, it can be anosmia, hyposmia can be. And among the minor factors comes the headache, fatigue, cough, or some ear pain, etc. So, if the patient had 2 or more major factors, or 1 major or 2 minor factors that last for the duration is more than 12 weeks, then we can label it as a chronic rhinosinusitis. So see the difference. In the acute sinusitis, duration was less than or up to 1 month or 4 weeks. Here, the duration is more than 12 weeks. And the signs symptoms were divided into major and minor factors. So if the patient is having 2 or more major factors, it is chronic sinusitis. Or the patient is having 1 major or 2 minor factors, then it is, again, it is a chronic sinusitis. The symptoms, there are some other nasal disorders where the symptoms can be similar to it. That is like nasal obstruction, nasal congestion, postnasal drip, PND are the most common symptoms that we can see in some other nasal disorders also. But the thickening of the or hyperplastic sinus mucosa, hypertrophy of the inferior turbinate, these are the leading symptoms that can differentiate from the other nasal. So if there is a nasal obstruction, postnasal drip, and nasal congestion, and we didn't see the thickening of the sinus or nasal mucosa, so we can't label it as a chronic sinusitis. Again, hypertrophy of the inferior turbinate is also one of the common signs which we see in the sinusitis. What are the additional measures of diagnosis? These are discolored nasal discharge, as I have told you that nasal polyps may be or may not be edema or edema of the middle meatus, ethmoidal bulla. On the plain sinus X-ray or CT scan, we can diagnose. So these are the measures for diagnostic, that is examination and diagnosis, that is radiological diagnosis, the radiological investigations. Again, it has multiple causes. It can be transformed from the acute sinusitis. How? If the duration, patient is having acute sinusitis that is less than 4 weeks, and it extend and lead to the mucosal dysfunction and chronic infection. So it can be transformed into the chronic sinusitis. A patient is having acute sinusitis, once it gets relieved, and then again, if he is getting again and again the acute sinusitis, episodes of acute sinusitis, so the patient can lead into the chronic rhinosinusitis. Symptoms are more varied in chronic rhinosinusitis when compared to acute. Medical management. Antimicrobial, whenever it comes the word you term antimicrobial, it means that it is antibiotics. So antimicrobial therapy, a 4-week course of first-line antibiotics. First antibiotic that the most, it is given against those pathogens. Every pathogen have sensitivity for some sort of antibiotics. So first-line antibiotics should be given to the patient, that is 4-week course. Macrolides group of antibiotics have shown a very better effect, or better results in such patients, especially in those with having polyps. And nowadays it is a rule to give a macrolide to a patient with sinusitis with polyp. Topical intranasal corticosteroids are yes, it is a treatment of choice. So these 3 points you must remember. Systemic corticosteroids are again potent anti-inflammatory agents, and it is universally recommended. But whenever you give a systemic corticosteroids, it is mandatory to give it in tapering dose. Tapering dose means if you are giving the corticosteroids planning for more than 2 weeks, then it should be in a tapering dose. That's starting from a large or high dose, and then coming down towards a small dose. Suppose you are giving 4 tablets TDS for 3 or 4 days, then 3 tablets TDS for 3 or 4 days, and coming down. At the end, you give 1 or 2 tablets for 1 or 2 days, so that starting, it is you can say that is an inverted pyramidal shape. The patients having gastroesophageal reflux, we give H2 blockers, and it has been studied for some time, and researches are still going on, that H2 blockers which we use for the gastroesophageal reflux in patient, it have some better results in sinusitis. If a child come to us with the history of sinusitis, and we have confirmed it by examination, history, and X-ray, which we do for adenoids, nasopharynx, and if there is adenoids, and the patient is having history of sinusitis, so one of the treatment in such children is to do adenoidectomy, to remove the adenoids, so the nasopharynx is cleared from the adenoids, and then there are chances that the patient get relief from the sinusitis. Antral washout, that I have told you, that antral washout is a procedure which was initially used few years back to clear the maxillary sinus from the secretions or fluid by means of trocar cannula. That was termed FES, functional endoscopic sinus surgery. This is the advanced surgical technique which is used for the sinusitis, for removal of the polyps. Any patient with having multiple sinuses involvement, maxillary sinus, ethmoid, frontal, all the sinuses can be cleared with the functional endoscopic sinus surgery procedure. And also the polyps are removed if the polyps are there. Thanks. So you will get your assignment and return it clearly. You must listen to these directions, so no confusion and no query about it. Write the answers to the assignments in your own handwriting and send it to me. Second, clearly write your roll number and name so that we can clearly mark if any one of you have not written their roll number properly, clearly, name and class. So it means that they have no registration with us. So please be careful and send it in a specified time. Whichever the date you have given, to send it before that date. It means it is mandatory to send it before that date so that we can compile your result, because this is the second assignment and second lecture given to you and before the previous one. So we have decided the date, and after that date, no assignment will be entertained.